Hello, this is Dr. Marcy Crisp, and I'll be giving a lecture over the female genitalia. So, the assessment of the female genitalia is a very important part of the physical assessment for the female patient and should be performed routinely. They might be in your clinic with a specific complaint. They might be there for birth control or there for a well child exam, for a well adolescent visit, but they are part of an overall well woman examination, and the exam is still part of a female's health even if they've had a hysterectomy, and we'll go into that a little bit more later in the presentation. So we'll cover, doing the review of systems on female patients, taking a good health history. We'll talk about some specific population-specific health screenings, and question it. And we'll also cover examination of the anus and the rectum, which can be performed at the same time during the examination. So we'll kind of go into a preview of the physical exam. The patient is, of course, in a lithotomy position. They have their feet up in the stirrups of the bed. Their thighs flex. Their bottom is at the end of the table. So you can get a good view of the external genitalia, and which will prepare you for examination of the internal genitalia. You will inspect the pubic hair characteristics, the distribution, the color of it. This will be one of the ways that you can do your Tanner staging of sexual development. You will inspect and palpate the labia for symmetry of color, caking of discharge, any inflammation, abscesses, irritation, excoriations, or swelling. This will be an opportunity to inspect the urethral meatus and the vaginal opening or introitus for discharge, for lesions or bumps or caruncles, for polyps, for cysts, for fistulas. Maybe they have a fistula. This will be an opportunity to milk the skin glands, which are by the urethral meatus, and to palpate the Bartholin glands. You will also inspect and palpate the perineum for the following smoothness, and perineum is the area between the vagina and the rectum. For smoothness, for tenderness or inflammation, for fistulas, for lesions, growths, warts, any abnormalities. You inspect for bulging, urinary incontinence as the patient bears down. Make sure that their bladder's not sticking out of their vagina, or any just gross abnormalities. Inspect the perineal area in the anus for any for the skin characteristics, but do they have any lesions? Do they have any hemorrhoids or other masses that should not be there? Any fissures, any inflammation? When you proceed on to the internal genitalia speculum exam, after preparing the patient and you've already done your interview and everything, you've already done your external, this is a good time to go into the internal exam. Often I will put a finger or two just on the posterior aspect of the vagina, and just kind of so the patient knows where to expect, relax these muscles here, and you can just insert the speculum on top of your fingers as you pull them out, and it really creates a comfortable experience for the patient. You're inspecting, looking at the vaginal walls, but you're also inspecting, when you get to the cervix for its color. We know that there are certain changes with when we don't have too much, or we have an excessive amount of estrogen, such as in pregnancy, and the cervix does appear different during that state, but also in postmenopausal women, it's more pale in color. So you can learn a lot about just the general health and the general of what's going on with your patient just by looking at their cervix color, the position of it, the size of the cervix, the size and shape of the os. Have they had lots of babies? This is a parous cervix. or is it a nulliparous appearing cervix that has a very small hole instead of a slit? Look at the surface characteristics. Is there any lesions or discharge or cysts on the surface of the cervix? And is there any discharge coming from it? Any bloody discharge or purulent discharge or just mucus? So during the internal genitalia speculum exam, you'll collect the necessary specimens, whether this be a culture for gonorrhea and chlamydia, a wet prep, a pap smear, and you've inspected the vaginal walls for the color, the surface characteristic, and any secretions, cysts, bumps, abnormalities. On the bimanual examination, insert the index and middle fingers of one hand into the vagina, and you'll place the other hand on the abdominal pelvic midline. And you palpate the vaginal walls for their smoothness, tenderness, for any lesions that you may not have been able to see, but now you have another part of your sensory being utilized, and often you can feel things that you cannot see. Palpating the cervix for size, shape, length, position, mobility. Did they have any tenderness whenever you moved it? Palpating the uterus for its location and position, its size and shape. Sometimes if they have a big fibroid tumor, you will find that it's enlarged and a little bit more firm. Does it move around easily, and was there tenderness experienced by the patient? Palpate the adnexal area where the ovaries are for their size, shape, consistency, tenderness. You often don't feel them on an examination. Sometimes you do. Sometimes just by seeing that the uterus is displaced, that will kind of clue you in that there may be a big adnexal mass or cyst on an ovary, or if they have significant tenderness on the bimanual examination. It is occasionally appropriate to do a rectovaginal examination, where the index finger is inserted into the vagina and a middle finger into the anus. This assesses for the sphincter tone, and it allows you to palpate the rectovaginal septum for thickness, tone, and nodules. It allows you to palpate the posterior aspect of the uterus and the anterior and posterior rectal wall for any masses, polyps, hemorrhoids, strictures, tenderness, and then you can do a fecal occult blood testing or look at the characteristic of the feces whenever that hand or glove is removed. So going into the basic anatomy and physiology, the external female genital organs include the mons pubis, which is the fat pad, and then you've got just the labia majora, which is the fatty tissue, folds of tissue that are on the outside of the external genitalia, and then you've got these smaller folds, which are the labia minora, and they are just on the inside of the labia majora. You've got the clitoris, which is erectile tissue. Also in the external genitalia exam, the vestibular glands, the skein, which are the periurethral glands that you can't always see but are there and you can milk, and the Bartholin ducts. Sometimes that is an area of where people will have cysts or abscesses come up that you have to address. You've got your vaginal vestibule, the vaginal orifice, and the urethral opening. The urethral opening is between the clitoris and the introitus of the vagina. So here is a good representation that kind of shows just anatomically where all of these structures are, and I'll let you, this might be something good to just keep for future if you get confused on where things should be. I think most of us as nurses have probably put in a Foley catheter and know where these structures are, or are female and have these structures, but this is a good diagram just for future use, because we are doing a higher level of thinking where we're actually thinking not just like where is the urethra to put a catheter in. We're looking at where are the Bartholin glands, where's the clitoris, are these normals, does this look like normal anatomy, or is it a variation of normal, or do I see something abnormal? So it will be important for you to know these structures very well. The internal genitalia, we've got the vagina, of course, which is a tube-like structure. We've got the uterus, and of that we've got the fundus, the body, and the isthmus of the uterus, and then the cervix, which is the part that we see and we collect the pap smear and some of our endocervical specimens like GC chlamydia from. We've got our fallopian tubes and our ovaries on the internal genitalia as well. It's a good diagram that just kind of shows, this obviously would be the speculum in the vagina. So this is the part that you see whenever you're looking inside. And obviously on your bimanual exam, these are the structures that you're feeling for. By just, putting your hand up here, sometimes that can just place them down so you can feel ovaries and the uterus a little bit better. I love this cross-section of the anatomy because it really puts into perspective when there is an issue. When there's a hysterectomy and they take out the uterus, the vaginal cuff is here, so the uterus is gone. The bladder is here, so when we have a cystocele, obviously, we'd have the bladder coming down here in the vagina. We've got the rectum here. If we have a rectocele, we've got the rectum coming here into the vagina. So it kind of puts in perspective the anatomy. Often your patients will be constipated and you can feel stool in their colon. Sometimes constipation is a significant cause of pelvic pain, particularly left-sided pelvic pain, and should be in your list of differentials when you're working up pelvic pain, because constipation, obviously, you can tell that if this is full of stool, how it could maybe displace some of these structures or cause pain, referred pain in a different area. So it's very important to just know the relationship between, that's why we want our patient to empty their bladder. Obviously, if we're going to be putting something inside the vagina, we want an empty bladder because we're going to be displacing it, and that might just make for a more comfortable exam for our patient if we keep that in mind. But this is a great cross-section of the body. The menstrual cycle. I'm not going to go a lot into the different phases of the menstrual cycle, but you do need to understand the menstrual cycle and understand where your patient is at on their menstrual cycle, because whenever you're working up pelvic pain, it is very important to know where they're at in that. Is it premenstrual pain? Is it ovulation pain? Is it pain during their actual period? And sometimes that can give you clues to what's going on with them, which will ultimately decide how you address those issues. This is a good chart as well for future use. Maybe put in your book of pearls for whenever you get further in your curriculum and you talk about when you get more into how birth control works and the different hormones within the brain, and how the process of ovulation and how the different drugs affect that. I'm not going to go into all that with this presentation, but this is a great chart for future reference for you. The bony pelvis, 4 bones. There's the ilium, ischium, pubis, and then the sacrum and the coccyx. There's 4 pelvic joints, the symphysis, pubis, the sacrococcygeal, and the 2 sacroiliac joints. Back pain can be referred back pain can be a significant source of pelvic pain often. And so again, knowing these bony structures, knowing any abnormalities with the patient, maybe they broke their coccyx and we need to adjust their exam just a little bit. So just knowing where these structures, where they are anatomically, and if your patient has any issues with them can kind of aid in your exam often. Two parts to the bony pelvis, the flared out iliac bones, and then the true pelvis, which is the lower curved bony canal. The true pelvis has inlet, cavity, and outlet. here is a picture of the bony structures, our sacroiliac joints, the sacrum, we've got the coccyx, and you can just see the different structures there. In infants and children, you occasionally in primary care will have to at least do an inspection of these, but I have had to do speculum and you know, appropriate age-appropriate examination of children, female children and infants at times, to do maybe a follow-up for sexual abuse. Maybe they had an injury, they fell on their bike and they're having bleeding that's not age appropriate, and we need to look at those structures and make sure everything is okay. Sometimes we'll have vaginal discharge in a child that has to be worked up, not only to treat them appropriately to make sure that there's not any that they don't have an infection that would be consistent with sexual abuse and things like that. So I work in rural primary care, and I don't do these exams often. I'm not a SANE certified nurse, but I do these exams often enough in my practice. They are appropriate and very much part of primary care, but you need to know just kind of some basic things about them, and so that it's an appropriate exam. In infants and children, the vagina is narrow. The cervix comprises most of the uterus. The ovaries are immature. Labia majora is hairless. The hymen is intact. And so we want to be good stewards of maybe not doing, we want to do the least invasive exam possible to get what we need. But sometimes it is necessary depending on the circumstances. Genitalia grow incrementally in childhood. In adolescence, they hit puberty, and this is where their reproductive organs start to function. Their external genitalia increase in size. The clitoris becomes erectile in response to stimulation, and they start to develop pubic hair. The vagina does lengthen, and they start having more acidic vaginal secretions. This is a protective mechanism for them. This is one thing that will keep them from getting, infections, yeast. This is why postmenopausal women and, women who have, or girls who have not started their period are at higher risk of getting things like yeast infections and opportunistic type infections, because they don't have this acidic pH protective nature from the hormones in place. The uterus, ovaries, and tubes increase in size. The uterine musculature and vascular supply increase, and the endometrial lining thickens in preparation for the menses. Pregnant women, there's increased levels of estrogen and progesterone. This causes the mucous membranes in the internal and external genitalia to be very to have a lot of vascular congestion, swelling. Their vaginal walls are thickened. There's increased vaginal secretions in response to these hormones, and so their cervix will appear more bluish in color, and their pelvic cartilage is softer. They do have strengthening of their pelvic ligaments in preparation for all the action that's going to occur with delivery of throughout the pregnancy and delivery of the baby. In older adults, they go through menopause. They don't have those hormones that premenopausal women have. They're not having periods. And that just response of the decrease, since they don't have the endogenous estrogen anymore, their external and internal genitalia do decrease in size. The tissue loses its elasticity and tone, can often become shiny in color and thin. Sometimes it can make the vagina narrow. They lose that natural lubrication. They lose sex drive, and sometimes intercourse can be painful in nature. So it's important to, when we get to the assessment part of this, to talk to them about these issues, because a lot of times we can treat issues that are associated with menopause to make the patient so much more comfortable and improve their quality of life and their sex life, which is a very important part of health and well-being in our patients. So this is a chart that compares the size of the uterus during various stages of development. Okay, we'll go on to review of the related history. This is probably one of the most important pieces of any part of the physical examination of your patient, including the female genitalia. So, history of present illness. Why are they in your clinic today? Maybe they're having some kind of abnormal bleeding issue. You need to ask them about their bleeding, the character of it. Are you usually is your period usually regular? Do you get it every 28 to 31 days? How long does it last for? Sometimes they'll say, my periods are always regular and I'm in the clinic today because I've been bleeding for 2 weeks. Ask them what is an abnormal amount of bleeding. And you may have to say, how many pads or tampons are you soaking during a day? We've got some people, though, that will have 3 drops on a maxi pad and change it. We've got some that will soak it completely through, but talk to your patient about it. The way that an average box of tampons, I'm not talking about the jumbo packs, I'm talking about a regular box of tampons or a regular box of pads is the average, just shy of the average woman's menstrual cycle. And so sometimes it's just so it's clever marketing on their part, just so they have to buy an extra package before their next cycle. But if they're using about a pack of tampons or a pack of pads during a menstrual cycle, that's usually about average. Now, if they're going through a pack a day, obviously that would be more normal. Are they passing lots of clots? Are they having a lot of pain with it? Are they having any discharge with it? Did the bleeding come on after an event, like they fell off their bike and now they're bleeding? Or they are bleeding just after intercourse, or after running a marathon? So really just ask them about it. Have they had changes in their flow? When are they bleeding? Are they bleeding, certain times out of the month? Are they on a medication that may have caused them to bleed? Maybe they changed their birth control recently. Maybe they were started on a medication like metformin and haven't been having periods, and suddenly, they probably have PCOS or their diabetes is under control and they start ovulating again and start having periods after they haven't for a while. And so really assessing what are their current medications and are they taking anything that may can affect that. Are they having any pain? The character of the pain. Is the pain sharp, dull, aching, burning? Where is the pain located at? Does it come with any other symptoms? Do they have bloating with the pain? Are they having trouble going to the bathroom? Are they having any burning or hurting whenever they urinate? Where is it at within their menstrual cycle? Is it the week before? Is it during? Is it after? Is it all the time? Is there any relationship to the menstrual cycle? Are they sexually active? Are they having pain during intercourse? Relationship to body functions and activities. Maybe they're constipated. I talked in earlier slides about constipation. All those structures are very close together. They're neighbors. And when somebody in the neighborhood is sick, it often can affect all the structures within the neighborhood. Do they have a bladder infection? Do they have, are they constipated? Are they having diarrhea? Do they have colitis? Do they have something going on that's related to their body function? And then activities. Is it worse when they're doing a particular activity? Is it only during intercourse? Is it just when laying down at night? Things that make it worse, things that make it better. What modalities have they tried to help it? Have they taken ibuprofen? Have they done a heating pad? Does this pain come on every month? Just really getting an idea for where their pain is. Is it localized on one side or the other? Is it right in the middle? And have they had any previous medical evaluation for it? Sometimes patients may not come right out and tell you, but maybe they've had an ovarian cyst in the past that this pain feels similar to. That's a great question. Have you ever had this kind of pain before? So that's a great question to ask. And did it require any medical treatment? Have you had surgery on your pelvis maybe to remove endometrial implants? And is there any chance you could be pregnant? Are you sexually active? What kind of contraception are you using? Is it reliable? What have they been doing? Have they been douching? Have they been using some sort of cream or ointment or home remedy? So really doing a thorough history and interview on your patient is so important. Do they have a discharge? The character of it. Is it thick? Is it cottage cheese-like? Is it thin? Is it green? Is it yellow? Is it red and bloody? Is it dark blood? Is it bright red blood? Is it white? Does it have an odor? How often do you get it? Is it just during different times in your cycle? Is it just since you started this new kind of birth control? Do they douche? We know that the body has a very effective cleansing mechanism for itself, for keeping itself clean, and that we should not douche. Douching changes the pH and alters the normal flora, and we know patients have a higher incidence of bacterial vaginosis and yeast infections when we douche. So really discouraging our patient and asking them if they douche, asking them what kind of products they use. You don't need a special soap for that part of your body. You don't need to use Dial. You need just a simple, gentle cleanser, like you do for every part on your body. Bacteria are good. Sometimes the normal flora bacteria are good, and they really are a good defense against things like bacterial vaginosis and yeast and other types of infections. So really talking to them about douching and products such as, lubricants maybe that are scented or flavored, because often those can be very irritating. Clothing habits, they need to be wearing cotton underwear. Maybe they go without underwear, maybe they wear thongs, maybe they wear this issue started when they started wearing super tight pants or skinny jeans. So talk to them about their clothing habits. Presence of discharge or symptoms in their partner. If their partners, it burns when they pee also, we probably need to be screening, which we're probably going to be doing anyway, but, we're more inclined to think that this is a sexually transmitted infection. Do they use condoms? Not only to assess for pregnancy and safe sex practices, but also often people can be sensitive to latex, and maybe their pain or their irritation or their problem is being exacerbated by a sensitivity to the material that the condom is made out of. So that's an important thing to assess for. It could be a contact dermatitis and not just as simple as that. We need to do some counseling or switch to non-latex condoms. Associated symptoms. Are they having pain with their discharge? Is it worse after intercourse? Are they having fever? Other nausea, vomiting, other associated symptoms within their body. Again, efforts to treat. Have they used anything over the counter? Monostat, Vagisil. What modalities have they used to self-treat? And what medications are they on? Sometimes you will put somebody on a birth control pill or any kind of hormonal type of birth control, or take them off of that, and that will in turn change the nature of their vaginal discharge. Their normal discharge will be different in response to the exogenous estrogen that they're getting. Have they been on any antibiotics recently? We know that antibiotics can put you at a higher risk of superinfections in the vaginal area, and a higher risk of getting things like bacterial vaginosis and yeast infections because it alters that normal flora. And so asking, have you been on any antibiotics recently, is important. And some are more broad spectrum antibiotics are worse at doing that. Talking about their premenstrual symptoms, how often they get them, the frequency of them. Is it enough that they interfere with their ADLs? Any psychological symptoms that they have with it? Are they sad? Are they crying? Do they have premenstrual dysphoric disorder? Are they so bloated that they're missing work? Talk to them about relief measures to do that, and any aggravating factors. Was it better when they were on hormonal birth control? Is it worse? Are they swelling? Are they having to take Tylenol or ibuprofen or other analgesics or their grandma's hydrocodone? Any diuretics that they may be taking over the counter or prescription. So really asking them about their premenstrual symptoms. Or ladies who come in with menopausal symptom complaints, talking to them about, looking at the age that they are and their symptoms that they're currently experiencing. Are they too young to be experiencing menopause? Have they, or is this postmenopausal bleeding? Have they gone a year without periods and now are bleeding? So your workup's going to be different based on that, because then we would think, postmenopausal bleeding is uterine cancer until proven otherwise, and we might be inclined to do a uterine biopsy on that patient. What symptoms are they having? Are they having vaginal dryness? Are they having hot flashes or night sweats? How old was their mom when they went through menopause? Did anybody in their family have cancer of any kind of their not only their ovaries, uterus, cervix, but also of their breasts? Have they taken hormone replacement therapy? Are they on a medication for, say, treatment of breast cancer that blocks estrogen, or for osteoporosis that may be causing them to have menopausal symptoms when they previously didn't, such as estrogen and tamoxifen? And so talking about what medications they're on, and, are their hot flashes disabling? Are they really affecting their quality of life? Are they having depression? Talking to them about their feelings about menopause. Do they want to consider hormone replacement therapy? You need to be equipped to give them the facts on hormone replacement therapy, about the risks associated thereof, but also the benefits of it. A lot of times there are women suffering that need hormone replacement therapy, but we are too anxious or too ignorant to know enough facts about them to offer that as a reasonable method. There are lots of other modalities and medications that we can use to treat menopausal symptoms that aren't hormones. So and your other courses will help you put those in your toolbox to bring up at a later date. But the perimenopause and menopausal time period can last up to 10 years in a woman's life. This is a very important time in the lifespan. So get comfortable with asking these questions. Sexual health is a very important part of health and well-being for all for all living creatures, but for human beings are no exception to that. And so really talking to them and being open about their sex life and telling them it is important, and we want you to, have satisfaction, and we want you to have comfort, and, really getting comfortable and developing that good rapport so they're open talking to you about these things. Infertility can be a very hard thing to talk about. You need to talk to them about their length of time attempting pregnancy. Usually, if it hadn't been a full year, it's not really under the umbrella of infertility yet. Sexual activity pattern. If your husband lives out of town and you're only having sex like 4 times a year, probably not going to have, your chances of getting pregnant obviously are going to be less. Knowing what your fertile and ovulation period is within the menstrual cycle, their length of that cycle, when they need to be having intercourse, do they have other metabolic issues that you need to work up going on? Do they have PCOS and are not ovulating, or something structurally wrong? Maybe they've had some ectopic pregnancies, or they're missing an ovary for whatever reason, or they have a lot of scar tissue from having pelvic infections from years past. So really just talking to them about their past sexual history and assessing for any metabolic issues will be important. Do they have any structural issues? Are they under a lot of stress? Are they healthy? Do they have good nutrition? Are they exposed to any kind of chemicals that may be causing this? I took care of a patient recently who was not necessarily experiencing infertility, but changes in her menstrual cycle, some extra hair growth. And I got to talking to her through the history, and she had been doing massage therapy routinely on a client who we later found out used a topical testosterone paste. And so she rubbed on him an hour every once or twice a week, and had therefore, with bare hands, had absorbed some of it. So we had to modify how she did her policy on giving massages and just her exposure to those things that she didn't even think about. And so it's things like that that get an important history. They may have exposure to chemicals and substances and hormones that they don't even realize, but kind of bringing that to their attention. Partner factors. Maybe it's the partners. Maybe they have a low sperm count. Maybe it's something going on with them that needs to be evaluated. And what workup have they had to date on this? And how much do you need to do within your scope and setting before you refer to a specialist? And infertility, I will work this up to a point. Make sure they don't have any metabolic monsters. Their thyroid is under control. They don't have diabetes, or I'll work them up for PCOS. But outside of that, I typically will refer them to a gynecologist or a specialist in this area. We have plenty of gynecologists in the surrounding areas that I feel are capable of doing this. And so I don't usually do a $10 million workup and then before I send them off. I usually will do a PAP and a basic workup, and then so that way when they get to the specialist, it is a very valuable appointment. A lot of the basic things have been done. I have set up the referral nicely so the specialist can kind of move on to these other things that are a little higher level and more specialized care and diagnosis of their condition. Are they having urinary symptoms? We know that dysuria without evidence of infection is chlamydia until proven otherwise. Does it burn when they go? Are they having frequency and urgency? Does their urine have an odor? Are they having any itching and burning in the vaginal area? Have they tried anything like azo or pyridium, the urinary tract analgesics or antispasmodics? Do they have a history of kidney infections, bladder infections, recurrent urinary tract infections? Do these seem to be coming up after they have intercourse, or are they related? Do they seem to be related to that? Have they had any surgeries on their bladder, any kidney stones, things like that in your health history? Let's talk to them also about their menstrual history. How old were they whenever they started having periods? When was the first day of their last menstrual period? That needs to be asked on any patient within, unless they're 80 years old or 5, you need to be asking when their last menstrual period was, because at every visit, because this makes a difference whether they're in there for a sinus infection or a UTI or depression, to see, are they pregnant? And kind of assessing, are they having regular periods? Sometimes I'll say 4 months ago they're not sexually active, but they should be having periods. So that brings up another dialogue of talk. But we have a lot of medications that just are simply not safe to give during pregnancy or during certain trimesters during the pregnancy. So you have to know that. That is a very basic, very important part of their past medical history, is when was their last menstrual period. How many days does their cycle last for? The character of the flow, is it heavier the first few days and then lighter? Do they pass a lot of clots? Do they have a lot of pain during their period? Do they have any bleeding in between their period or any pain? And then any premenstrual symptoms, as we discussed in the earlier slides. What is their obstetric history? How many times have they been pregnant? How many term pregnancies have they had, or preterm pregnancies? And then why, if they did have preterm pregnancies, was it because of an infection or an incompetent cervix? Did they have preeclampsia or HELLP syndrome or some kind of something that caused them to have to deliver early? Were they in an accident? Have they had any abortions, either induced or spontaneous? Their number of living children. And if they don't have living children, asking them what happened. Did they die at birth? Was it an accident after? Did they have cancer? What kind of cancer? So just talking to them about their living children sometimes can give you any chromosomal abnormalities that they might have. Any complications of their pregnancy. Again, did they have high blood pressure during pregnancy? Did they have preeclampsia? Did they have any infections? Or how did they deliver the baby? Was it via C-section? Was it, and if they did a C-section, why did they do a C-section? Was it an emergency section for failure to progress? Was it a C-section because the baby weighed 14 pounds because they have gestational diabetes? Was it was it a vaginal delivery? Were there any issues with the vaginal delivery? Maybe their uterus, prolapsed, or just asking, or with the baby itself, maybe the cord was wrapped around a neck, or breech births, things like that. Menopausal history. How old were they when they went through menopause? Did they have any menopausal symptoms? Have they had any bleeding since menopause? We talked about that in earlier slides. During that perimenopause and menopausal period, are they using condoms? Are they at risk of getting pregnant? Feelings about menopause. Can be, a lot of people have their own feelings about menopause and how that means to them, how they're perceived as themselves just being a woman, and their sexuality and their health and well-being. So which has been shaped by their worldview. So talking to them about their feelings about it. Again, their mother's experience often can be valuable. Medications. Are they on any current medications? Maybe medications that have induced this. Maybe they have surgically induced menopause. Maybe we've taken out their ovaries and their uterus, and they're 30 years old, and they've been thrust now into surgically induced menopause. And we need to help them through that phase in their life. Are they using any complementary or alternative therapies to manage this? We know soy is a plant estrogen and can be very effective in treating menopausal symptoms. Black cohosh is another herbal remedy that they may have tried. And often these may be appropriate things to suggest before we just jump into hormone replacement therapy with either synthetic or bioidentical estrogen. So talking to them, have you tried anything alternative? Have you tried any kind of, and just talking to them, because often they just haven't told you about it. Their gynecologic history. Have they had a prior pap smear? If so, when was their last one? Was it normal? Who did it? Have they ever had an abnormal pap smear? If they have, what was the follow-up of that? Did they have to have a leap or a cone biopsy? Have they had a history of HPV testing? And often they know that and can answer that and can tell you if it was a high-risk type or not. Knowing if they've had those procedures for abnormal pap smears, sometimes can give you a clue on, do they have an incompetent cervix, and this is why they keep having miscarriages. Do they have any history of sexually transmitted infections in their past? How many times have you had chlamydia? Do you have genital herpes? We know that those things put you at higher risk of infertility, and ectopic pregnancy, as well as genital herpes and HPV for cancer, as well as vulvovaginal and cervical cancers. So any other vaginal infections, maybe they're getting BV every month for some reason around the time of their period, or after intercourse. And so talking to them about their history of vaginal infections. Do they have diabetes? When you have diabetes, particularly if it's uncontrolled, that causes you to have more glycosuria, which is like food for yeast. And so often you will get more urinary tract infections and more vulvovaginal mycotic infections, like yeast infections. Have they had any cancer of their reproductive organs, their ovaries, their labia, and their uterus? Have they had, uterine cancer? Why did they have that hysterectomy? Was it for benign reasons, or was it because they had a malignancy? That will have to do with the type of hysterectomy that they did. Was it a radical hysterectomy or supracervical hysterectomy, where they left the cervix in, which they wouldn't do for cancer? But that might, knowing their history of cancer, why they had certain surgeries, is very important, because often women, there's a surgical technique where they leave the cervix in and take the uterus. It's a complete it's a hysterectomy, and a supracervical hysterectomy. They take the uterus out, but they leave the cervix in. Those women still need to be screened with Pap screenings, and so, and they may or may not know that. So really getting a good history is so important. Do they have a family history of diabetes, of cancers of reproductive organs? We know that some forms of cancer are there's a genetic predisposition for. Maybe we've got a genetic mutation, and mom had ovarian cancer, maybe daughter carries the gene, or breast cancer. Maybe that their mother received DES while pregnant. I have 2 patients that have a positive, and this was a very specific time period. I'll have to go back and review, but I think it was the late 60s to maybe it was a period of about 3 to 5 years. So this isn't something that like every patient, we know if they're 25 or 30 years old that they didn't have a DES exposure, but there's a significant subgroup of women. DES is a type of estrogen that back then they thought they could give to women and it would prevent them from having miscarriages. While these years later we found out that exposure of their mother while they were pregnant to this has led to increased incidence of birth defects in those girls, but also puts them at a higher risk of malignancy. I have 2 patients that had DES exposure in my practice. One of them has 2 cervix. She has not been able to conceive a child. She's about in her early 50s now, and is not going to conceive a child. But when I do her pap smears, I have to label, and one of them is obviously like the primary cervix, and one is smaller over to the side. But I have to do 2 separate pap smears and label one cervix 1 and the location of it, and another one cervix 2 and the location of it. My other patient has actually a hooded cervix that looks very different from a normal cervix, and the collection technique is just a little bit more challenging, but I'm able to do it, and we just screen them and talk to them, about this. Have they had multiple pregnancies? And have any of their children had congenital anomalies? Birth defects, chromosomal defects, talking about their personal and their social history, what's their sexual preference, what is their cleansing routine, what kind of soaps and lotions and products are they using, what are they doing for birth control, what have they done for birth control in the past, what do they believe about birth control, history of douching, do they perform a genital self-examination, when was the date of their last pelvic exam and their pap smear, and do they use any drugs or alcohol, are they in a high-risk sexual, I work with a population, a low-income STD women's health population, and I see a lot of prostitutes, I see a lot of drug addicts that will exchange sex for money or drugs, and they will be quite honest with you about it. We still need to care for them in an appropriate manner, but that puts them in a higher risk category, just knowing that they are drug addicts or using meth, and talking to them about decision making and risk factors and how we can minimize that. Maybe they need help for the drug addiction. Maybe they need, just really being comfortable talking to your patients. Are they currently sexually active? What birth control they're using? Are they using safe sex? Are they using a barrier method? Are they satisfied with their relationship? I'll have but some people talk about their sex drive and talk about not having pleasure during sex. And then when you further ask questions, and you have the rapport to ask these questions with this person, and you talk to them a little bit about the dynamics of their relationship, and you find out that really it's not a positive relationship, and that there's all these underlying issues with it. And I tell them, sex is often the icing on the cake, and if the cake is rotten, so is the icing. So sometimes it's, you can't expect, if your mind is not there, to have satisfaction with your relationship and with your sex life. So sometimes that may just give you the capacity to point them in the right direction, maybe to marriage counseling, or just to kind of talk to them on some factors to help. Do they have pain during intercourse? Is it pain when, on entry into the vagina, or with deep penetration? Is it because they don't have enough lubrication? For whatever reason, maybe they have a yeast infection that causes them to not have adequate lubrication, or they're just not into it, or they don't have enough estrogen. Are they achieving an orgasm? Infants and children, if they do have bleeding, you need to know about the character of it. You need to know if they children put will put foreign objects in their ears. They will put them in their nose. They will put them also in a vagina. So, that's something you just got to be aware of. You need to be suspicious, but not overly suspicious, because I don't think this occurs, depending on what you read. Not every child that comes in your office with a discharge or pain to their private area, yes, you need to have a little bit of a red flag raised, but not everything needs you to be overly suspicious about that. But you need to be suspicious enough that that you do an appropriate workup and you have all the factors in place to make that decision. But be aware of sexual abuse and how, if you have a child or an infant with vaginal bleeding or discharge, or that needs to pop into your mind. But often I think you'll find it's not the case, but it needs to go there. And you do need to, I've checked for gonorrhea, chlamydia in children before. Luckily, I've yet to have one come back up, but I checked for it, and which needed to be done. Are they having pain? Do they have any other problems going on? Are they having discharge? Babies get yeast infections. They get candidiasis, diaper rashes. Are they being cleaned and changed? Have they had diarrhea recently? Obviously they can get infections in the vaginal, and are they having urinary symptoms? Are they having any fever, nausea, vomiting? And so just talking to them about, especially when they're diapering or they're pottying, learning to potty and learning to care for their genitalia themselves after pottying. And sometimes you'll see just a kind of increased incidence of yeast infections and things like that during that transition period, where the child is kind of getting a little bit more independence, but not maybe doing the kind of care that they were getting when they were in diapers. Excessive crying that can't be resolved, loss of appetite, fever, nausea, vomiting, masturbation. This needs to be something you're comfortable talking to children that fit within that age range about, because this is something that happens. And I sometimes will have 12-year-old boys that their parents bring them into the office for dysuria and pain, and their urine is totally clear, and then you have to do a health history to see about habits, and not making them feel ashamed, or just, counseling them on what's age appropriate, counseling the parents on that, and doing it in a way that is appropriate and doesn't embarrass them. Adolescents, you ask the same questions as you would any adult female. If you can talk with the teen in private, please do. There's a lot of times that teens will be open and honest with you, but if their mom and dad are in the room, they may be less open with you. And a lot of times I find, even if the children are minors, the parents are okay. They want to get care for the teen. They're okay with them talking to you in private, so you can get a better history from them, because parents often know that they don't want to put their teen on the spot like that. Some of them do, some of them don't, but try to get an opportunity to talk with them, to develop that rapport, to tell them, this is not an exam that we use to shame people, to punish people. This needs to be, the health care provider's office needs to be a place that is safe, that we go when there's an issue, and they need to know that it is safe to come to your office, or safe to ask their parents, or to approach you for treatment when there's issues. And obviously there's some legal things that go with that, but it needs to be a safe place. Don't assume that just because they're young that they're not sexually active, or that they don't have any related concerns. And sometimes they have questions about their body that their parents are uncomfortable handling, or they've heard things from their friends that just aren't true and that you need to clarify. You need to pose them in a gentle, just matter of fact, we don't judge, it is our body, and be comfortable talking about it. I tell them, if you were in here with a throat infection, we talk about your throat for 15 minutes and you wouldn't feel ashamed about it. You're having an issue with this part of your body, and we're going to address it and move on. And so, really making them feel comfortable during the exam. Pregnant women, When is their expected date of delivery? What is their prior obstetric history, birth history, their menstrual history, any surgeries they've had, family history, have they been leaking any fluid, have they had any bleeding whatsoever, any pain, do they have any GI symptoms such as heartburn or nausea, vomiting, or constipation, which is common in pregnancy. Older adults, their menopausal history, symptoms associated with age or atrophic vaginitis, itching, painful intercourse, urinary problems. We see a higher incidence of urinary tract infections in postmenopausal women because they just simply don't have that acidic barrier anymore that women with the hormones, with the normal hormones you have with when you're having a period, so it changes the pH to not be as acidic. It's not as much of a hostile environment, so they are more prone to have infections. But not only that, they lose a lot of the tone down there, and so they can have increased problems with urinary incontinence as well. And so talking to them about that, maybe you need to do an estrogen, maybe your recurrent urinary tract infection is related to atrophic vaginitis, and we need to, see what's going on in the neighborhood, replace that with a vaginal gel, estrogen cream to restore just the pH and the tissue rather than just keep giving them antibiotic after antibiotic. So you can see how your decision making kind of comes in with these specific lifespan categories. And sexual changes in their self or their partner, their desire, their behavior, how it's changed since menopause. Maybe they have a spouse that has a chronic disease that they're dealing with, and just talking to them about that. Moving on to examination and findings. You will need several things for the actual examination. You will need drapes, your speculum, your glove, your lamp. I use a headlamp that I get from Walmart, or you can use a floor lamp that I just put on my headlamp, but you can, that way I can take it wherever I need it. But you can use a floor lamp, a water-soluble lubricant, any cultures that you might need, gonorrhea, chlamydia, a setup for a wet prep as well. Be sure that you have the sizes of gloves that you need, that you have the sizes of speculums that you need, and a backup available there in case, with most women you can tell what kind of size of speculum you're going to need, but sometimes their vagina is just longer than you thought and you need a longer one, or they end up having you need a smaller one, or maybe they have not had a baby and you need a, so there's different types. So have those readily available so you're not disorganized and having to leave the room and get other things. I keep my speculums in a drawer on a heating pad. But also I can warm them up under just warm water, or you can keep them in warm water, or not keep them in warm water, but have them in warm water to make them closer to the body temperature, so it's not putting a cold speculum in. And I'm talking about metal speculums. If you use the plastic speculums, you don't really have to do that because they are not necessarily cold and they adapt to the body temperature a lot more readily. So, have your PAP stuff, your glass slides if you need it available. Be sure that you have your spatula, your cervical brush, cytologic fixative if you are doing a traditional PAP and need to put it on the slide, culture plates or media, and your DNA probes, like I already said. Talk to the patient, explain the exam to them so they know what to prepare. Make sure the room is a comfortable temperature. It's not too hot and they're sweating and uncomfortable because their butt's stuck to the paper, or too cold and they're shivering. Not only do this, but say you're doing it. When you have the drape over to protect their privacy, when you have the drape over their legs, please say, I'm going to pull this over to give you a little bit of privacy. How do patients know that we protected their privacy? Because we tell them. Don't assume that they know that that's why you're doing that. I'm going to make you comfortable. I'm going to pull this over for your privacy. Have them empty their bladder prior to the procedure and make sure that the speculum is at an appropriate temperature and it's not too hot or too cold. You will assist the patient into the lithotomy position on the table and help stabilize their feet in the stirrups and slide the buttock down to the edge of the examining table. I tell them scoot your bottom to the end of the table till you feel like you're going to fall off, but don't fall off. You will drape in a way that minimizes exposure. Knees need to be covered, and symphysis and depress the drape between the knees. There's a way to fold it that's real fancy. I don't usually get into all that, but just make sure that you can see her face if you need to see if she's experiencing any discomfort. So that would mean that the top of the bed is slightly raised. Have your equipment nearby and easy in reach. You do need a chaperone always for an intimate invasive exam. So these are not exams that we ever perform by ourselves. You need to have a chaperone with you, a nurse with you, someone else with you in the room, not only to help for legal purposes, but also if you need to get something, you have an extra set of hands there, and it really makes the actual examination so much more simple when you have an extra set of hands. They're examining lamps so you can see things clearly. Wash your gloves and be sure you have gloves on the whole time during the procedure. So this is a patient draped in their dorsal lithotomy position. I tell them to relax their legs out to the side as much as they can. Makes for an easier exam. Their labia majora, you're assessing for symmetry, redness, swelling, tenderness, any excoriation, rashes, lesions, any discoloration, any varicose veins or varicosities, stretching, trauma. Do they have any scars from maybe a prior abscess removal or trauma? Their labia minora, you're inspecting for symmetry, moisture, color. It should be soft and homogeneous without tenderness. It should be free of inflammation, no excoriations, discharge, no ulcerations or blisters. Looking at the clitoris, looking at the size. Is there any atrophy? Is it too big? Is there any inflammation or adhesions? The urethral orifice, discharge, any polyps, any fistulas, irritation or inflammation. Looking at the vaginal introitus or the opening of the vagina, looking to see that they have adequate moisture, that it's not swollen, any discolorations or discharge, lesions, fistulas, fissures. Looking at the skin glands, they have the periurethral location, or is there any discharge coming from those? Looking at the Bartholin glands, their posterior lateral portion of the labia majora. Is there discharge? Is there masses? Sometimes they will have a cyst or an abscess in this area. Any tenderness to that area? Looking at their muscle tone, do they have a uterine prolapse? Assessing what kind of muscle tone they have. Their perineum, any tenderness, inflammation, fistula, lesions, growths, warts, cysts. Okay. And so I'm assuming this is a picture of a uterine prolapse or cystocele. But, obviously these structures should be in there and not visible from the external examination. Looking at the anus, the colors, do they have any skin tags, do they have any warts, do they have any hemorrhoids, scarring, excoriations. Looking at the color of the cervix, the position of it, their surface characteristics, any discharge, the size and shape, is it nulliparous or aparous in appearance. So this is the actual speculum examination of the internal genitalia. And you can see how the examiner is, her finger in there, kind of preparing the patient, inserting the speculum, opening the speculum up to visualize. You can see the position of the speculum, how it's down about 45 degrees, and then opens up to clearly see the cervix. And that is where we collect our specimens from, and that's a great view of the cervix there. So this is a nulliparous cervix in a woman who's not had a baby, and what a multipara or parous cervix looks like in somebody had. See how this one just looks like a little circular, and this one looks more like a slit. This is a great diagram that talks about the common appearances of the cervix. We have a normal nulliparous cervix here. We've got a parous cervix here. This is a multigravitous lacerated cervix. We've got an everted cervix where kind of the inner portion of the cervix is kind of out, and the mucosal cells have extended out to the surface, creating a raised erythematous appearance. This is an eroded cervix, and these are I always mispronounce this, Naboliathan cyst of the cervix, and you will see these commonly in clinical practice. There are a variety of tools that you can use to collect the Pap test. They can be wooden, they can be plastic. Here is a spatula, and obviously one aspect goes kind of in the cervical os, and this would be used to gather cells by turning it 360 degrees. Here's a brush for kind of the endocervical canal, and this kind of is like these two in one. So the Pap smear gets endocervical cells. It shows, what the structure of the cells, tells you if they're abnormal or if they have abnormal cells that are leading to cervical cancer. It sometimes will show if they have trichomonas. The pathologist will be able to see that they have cell changes related to that. Sometimes we'll show yeast. Sometimes we'll show a shift in vaginal flora. But that's what Pap smears test for is cervical cancer. Testing for gonorrhea, chlamydia, a DNA probe. Wet mount will show Trichomonas BV or yeast. The bimanual exam, feel the cervix, the size, the length, the shape, position, consistency, movement, any nodules, is it hard, is it tender. Uterus, pretty much the same thing, the size and position, mobility, and any tenderness they experience. And this shows the placement of the hands beautifully on the bimanual examination. You can see how with this hand right here that they're depressing the structures down so they can be felt easier by the examiner. So this looks at the various positions of the uterus, which are all variations of normal for your documentation. Bimanual exam, ovary, size, shape, location, consistency, tenderness, nodularity. Often you don't feel ovaries on a bimanual exam. I rarely do unless they're just very thin. Their adnexa, do they have any masses or tenderness in there? On the rectovaginal exam, which we will perform time to time, looking for their anal sphincter tone, their rectal walls. Do they have any hemorrhoids, masses, polyps, nodules, strictures, tenderness, fissures? In the examination of the rectovaginal septum, the tone and thickness, and any nodules there. You can feel the posterior aspect of the uterus. It kind of confirms your bimanual findings. And you can examine stool for color and for blood after. And here demonstrates the rectovaginal part of the examination. Infants, we would inspect and palpate the external genitalia only. Swelling, do they have and keep in mind that infants, and we're talking newborn infants, have changes in their hormones because they're outside of their mother. So often you will see an enlarged clitoris, an ambiguous appearance of it. They might have a little bit of a discharge. They might have some swelling. They might even have some adhesions. And some of those can be related to the hormones and that. So that's something we sometimes just provide some reassurance. And that's why we follow up with the infant kind of routinely and more often when they're newborns. And this shows the normal appearance of a newborn girl and then of a 2-year-old girl. Children, you will inspect and palpate their external genitalia, redness, irritation, swelling, discharge, or bleeding. You only want to do an internal examination if there has been bleeding, any discharge, and I mean discharge that sometimes you can see discharge on an external examination, not have to do an internal. But if they're bleeding or having discharge significant, maybe you've tried one thing and it's not helping, or you have any suspicion of trauma or abuse, obviously you need to go through the appropriate channels of that. Has it just happened? Is this a follow-up? But you might need to do an internal examination on a child. This goes into sexual abuse signs. You know, if they're neglected or abused in other ways, don't think that, you know, sexual abuse certainly can be part of that. If they have evidence of trauma or scarring to their genital, anal, or perianal areas, if they have something like genital warts or something that just shouldn't be in that area at their age, molluscum contagiosum is another viral. Doesn't always mean sexual abuse, but if you see it in the area of the genitalia on a child, you need to kind of be asking specific questions that address that. Do they have an STD? Do they have any anorectal problems like itching or bleeding or pain, incontinence, poor anal sphincter tone? Have they had any rashes or sores in their genital areas, vaginal odor, or pain? Do they have, are they having a lot of problems in school? Have they had dramatic changes in their weight or eating, depression, sleep problems, nightmares, sudden change in their behavior? Are they aggressive or destructive? They suddenly are avoiding certain people or certain places, or have these fears that are totally out of characteristic for what the child has been. Or are they using sexually provocative mannerisms that are not age appropriate, maybe touching other children or inappropriately, and just something that cues you into, okay, this is not an age appropriate reaction in this child. They've seen that somewhere or experienced that somewhere. We need to be thinking about sexual abuse. Are they experiencing excessive masturbation or sexual behaviors? Do they have an age inappropriate sexual knowledge or experience? At certain ages, they just shouldn't know certain things. And if they have, why do they know that? Do they have an older sibling that is being inappropriate with them? Or are they reading sister's diary? Are they being abused at daycare? Just really asking, how do they know that and why do they know that? Repeatedly inserting objects in the vagina or the anus. Child asking to be touched or kissed there by adults or people at school or other children. If there's sex play going on between children where there's 4 or more years of age difference, and anything that uses force, threats, or bribes. All adolescent females should have a pelvic exam within 3 years of attaining sexual intercourse. And I really should have updated this, but we actually are not doing pap smears in anybody under age 21. That is when we, even if they, regardless of sexual activity. And I will update this slide. I apologize. I went through them earlier and thought that I did, but actually this should say pap smear with cervical cytology starts at age 21 regardless of sexual history. They should be screened for STDs, however. And so we don't do pap smears to anybody under 21 regardless of sexual in normal risk women. I'm not talking about women who or children maybe that have rheumatoid arthritis and are on a disease-modifying agent, and so their immune system is knocked down and they're at higher risk of certain cancers and things like that, or maybe they have cystic fibrosis or HIV. People with healthy immune systems, otherwise healthy individuals, 21, we do not do pap smears under 21 regardless of sexual history. So I do a lot of first-time exams. I do a gonorrhea chlamydia check on all the adolescents. Even if I don't do a pap smear, I still do an exam. Need to talk to them about the exam and talk to them because they are often very anxious about it. It's the same positioning as for an adult. Use an appropriate size speculum. Often, if they haven't had a baby or, they're small, they're an adolescent, use a smaller speculum. Make it comfortable for them. All right. Pregnant women. Same in the non-pregnant women, but you need to be thinking about their gestational age estimation, uterine size and contour, pelvic size estimates, cervical dilation and length. Really needing to minimize lots of invasive pelvic exams in pregnant women, though, if they're unnecessary. Fetal assessment will be growth, position, well-being, the fetal heart rate, and fetal movement. And then during labor, their fetal station, where they're at in relationship to their presentation within the mother's pelvis. Where's their head at? So this has them measuring the fundal height to the top of the fundus from the symphysis pubis. And this has the location of the uterus at the different weeks of gestation. You can see about 20 weeks. The uterus is about the flow level of the umbilicus. And just kind of how it grows through the pregnancy. And this is Leopold maneuvers. I won't go a whole lot into that. Talk about the older adults. The examination is essentially the same. You may modify for comfort. Use a smaller speculum. Use a little bit more water-based lubricant if the tissue is a little bit more friable or thin. Inspect for age-related changes. The labia will appear flatter and smaller. The skin is drier and shinier. They may have gray or sparse pubic hair. Clitoris is smaller, and the urinary meatus may appear as an irregular slit or opening. The vaginal introitus may be constricted. They may not be sexually active. Multiparous older women, the introitus may gape. The vagina is narrower and shorter, and there is absence of the vaginal rugae there. So, again, use an appropriate size speculum. Their cervix is less mobile. Their uterus is smaller. Often you don't palpate ovaries. Their rectovaginal septum will feel thin, smooth, and pliable, and they usually have diminished rectal tone. Sometimes we'll have patients, we still need to do this exam, but we have to make modifications. I've had to do exams on people who have maybe paralysis on one side of their body and aren't able to get in the lithotomy position. I've had a patient who is sexually active and needs screening for things, and she has cerebral palsy and isn't able to do lithotomy positions. So you can do alternate positions based on your patient, but you still have to do the examination. So there are some alternatives, and just be aware that if they can't get in that position, that there are alternatives. They may not be optimal, but you can usually get it done. Some women get terrible leg cramps when you put them up, or they have hyperreflexia, or they have bowel or bladder alterations, functional, that make this exam a little bit different. And so just tailoring your exam to the needs of your patient will make it more comfortable and a more appropriate examination. So going into abnormalities, PMS is physical, psychological, and mood symptoms related to a woman's menstrual cycle. And this is just basic terminology. Infertility is the inability to conceive a baby over a period of 1 year of unprotected sex. Endometriosis is presence, growth, proliferation of endometrial tissue, so the tissue inside the uterus, in places outside of the uterus. And this can cause pain, it can cause infertility, and other things. So these implants of this tissue can be on the bowel, they can be on top of the uterus, on the ovaries, on the fallopian tubes, on the rectum, just various places on the bowel. And often this is difficult to diagnose. They diagnose it by direct visualization of the implants. So often you don't see this, or you won't see this. This is something that they open the patient up to do a laparoscopic surgery to figure out why they're hurting, and this is what they see, and they can remove it then. And this is a picture of endometriosis with the implants of endometrial tissue at places other than. And so this responds to hormones just like the endometrial tissue within the uterus. So it thickens, it sheds off, it bleeds, and it can cause pain and discomfort and infertility. And so you can see how it might be problematic to have endometrial tissue other places. And we treat that, we can treat that with hormones, birth control pills, or removal of the actual implants. It depends on the nature of the problem, the extent of the. Sometimes people can have a little bit of endometriosis causing a huge amount of pain, discomfort, and issues. Sometimes they can have just a little bit, and really the extent of the endometriosis isn't always reflective of the symptoms. Lesions from sexually transmitted infections, they can have condyloma acuminatum, which is genital warts, and due to the HPV virus, they can have molluscum contagiosum, which is caused by a viral infection, and it affects skin and mucous membranes in the genital area in adults. This is typically transmitted sexually. These are flesh-colored papules, usually about 2 to 4 millimeters in diameter, and they usually have an umbilicated center, and that's how you can kind of tell that's their characteristic feature of molluscum. Considered as an STI in adults, in contrast to the non-sexually transmitted infection that commonly occurs in children and other places. So this is genital warts, you can see. Syphilis, canker from that, skin lesion associated with primary syphilis, we treat that with penicillin. We will see outbreaks of syphilis from time to time. And syphilis, the painless canker will eventually go away, and then it will manifest other places and eventually can cause neurologic problems. So if somebody comes in with a skin lesion, it needs to be thoroughly evaluated. The condyloma latum are lesions of secondary syphilis. Sometimes you can see rash from syphilis, rash on the palms of the hands. You can see genital herpes, most commonly caused by the simplex 2 virus, but can be caused by simplex 1 virus as well, with the oral sex. And same thing with lesions on the mouth, not always type 1, they can be type 2 as well. Causes painful blisters, outbreaks of that in the genital area. It can be very distressing and predispose them for certain forms of vulvovaginal cancers in the future. So that is a syphilitic canker. And those were some pictures of outbreaks of the little blisters associated with genital herpes. The vulva and vagina, you can have inflammation of the Bartholin gland, commonly but not always caused by gonorrhea, so be doing cultures on that. Vaginal carcinoma does exist, and it's classified by the type of tissue from which it comes. And that's a swollen Bartholin gland. Vulvar carcinoma, it also is classified from the tissue in which it's come. I've actually done some vulvar biopsies because we've had skin lesions that are itchy and just don't look good and needs to be ruled out. Sometimes it's some of the lichen family of disorders with that. I have yet to find a vulvovaginal cancer, but sometimes it is appropriate to do a skin biopsy of those things because you need to rule that out. This is ulcerative squamous cell carcinoma in exhibit A of the vulva, and then a basal cell carcinoma of the vulva as well. And a simple skin biopsy when that lesion was much smaller could have got us a correct diagnosis and got her to the right place. Vaginal infections you'll see a lot of in primary care. Bacterial vaginosis, most common organism for that is Gardnerella vaginalis, and Again, it is caused usually when there's an alteration in the pH or the normal flora of the vagina, and this infection is allowed to kind of take over and overgrow, and it causes just some vaginal discharge and odor, kind of a fishy smell. It's worse after the period, worse after intercourse, and things that change the pH of it. Candida vulvovaginitis, or yeast infection, causes a thick white cottage cheesy discharge, external, sometimes internal irritation and itching, burning, swelling. Trichomonas is actually a protozoal infection caused by Trichomonas vaginalis, and these are actually flagellated little creatures that you can see under a microscope, and they're swimming around. They're quite impressive. This causes a very kind of frothy from the little tails of the flagellated protozoa, so that makes it kind of foamy, kind of green. Discharge can be copious in nature, a lot of it. I've done examinations on people with trichomonas, and it literally just poured out. It's quite neat to see this on a wet prep. They have a very friable cervix that bleeds easily, kind of looks like a strawberry. It's got little petechia on the, so that's where, sometimes when you do your internal examination of the cervix, you can see, hey, their cervix looks like a strawberry. It's got petechia all over it. Maybe they've got a green frothy discharge. Maybe this is trick, and your wet prep can confirm it, and you can treat them appropriately with Flagyl. Gonorrhea, chlamydia. Sometimes you don't have symptoms, particularly of chlamydia, but it can be a very dangerous infection, and obviously it doesn't help transmission when they don't know that they have it. So doing screening for that in our high-risk populations and younger people, and treating those according to the STD guidelines dictated by the Center for Disease Control. We treat gonorrhea with a one-time injection of Rocephin. We treat chlamydia with Zithromax. There are all alternatives for that, and the STD guidelines have that. Foreign bodies. The worst vaginal discharge and odor I've ever seen has been from a retained tampon. These can cause horrible infections, and they can cause sepsis and death. I can remember a colleague of mine, saying how she took care of a patient in the ICU one time, and there was sepsis, and nobody could really figure out where the source of infection. She'd had a $10 million workup and on vasopressors, and she went to do her pericare and saw that she had just, a vaginal discharge, and they ended up doing, while she was unresponsive, they ended up doing an exam on her with a physician on the case, and sure enough, she had a retained tampon. That was the source of the infection for her sepsis. That source was removed, and the patient recovered. Without that thorough assessment from the nurse, that may not have been caught. So, really think, foreign bodies, retained tampons can be, cause vaginal infections as well. And this is kind of the petechia on the cervix. This looks at a wet prep at the different microscopic differentiation of the vaginal infections. Bacterial vaginosis. These are clue cells, and they're big cells, and they look like they have little speckled things in them, and that's bacteria. Candida, you can see these long hyphae here. They're budding, they're branching off. That's indicative of yeast on a wet prep. And these are things you're going to be reading within your office. Exhibit C is trick, and of course you can't, there's not a little video of it, but these are they have little tails on them. I don't think you can really see it, but if you're looking at this under the microscope, these things would be wiggling and swimming around. Cervix, cervical cancer, two types of cancer, and they're both named for the cells for which they arise: squamous cell and squamous cell carcinoma, adenocarcinoma. And this is a cervical cancer lesion that's primarily around the external os area. And if we could catch cervical cancer with our naked eye, we wouldn't have to do Pap tests. So, again, the importance of the Pap test in screening. Uterus, uterine prolapse. Do they have herniation of the uterus beyond the vagina? Do they have uterine bleeding mid-cycle? talking to them about that. There can be tumors and conditions. Benign uterine tumors are pretty common and can often have to be removed with a hysterectomy because they're causing the patient just a lot of discomfort during intercourse or bleeding when they shouldn't be. Endometrial cancer is cell changes, cancer that is found in the lining of the uterus. Very important to screen for this in our patients that have bleeding that we can't really figure out, or any kind of postmenopausal bleeding. This is why we would never use unopposed estrogen in a postmenopausal patient that still had a uterus, because that progesterone is needed to balance that out. Otherwise, the estrogen will just have the endometrial tissue thicken, and it will cause, hypertrophy of the cells and eventually lead to cell changes in endometrial cancer over time. And so we use progesterone always, or only short courses of estrogen in postmenopausal women that still have a uterus. That's a very important risk factor. And I have run into this once in my practice. I saw a patient in the office, first time to see her, in with postmenopausal bleeding. Talked to her. She had been on unopposed estrogen, so Premarin, not Prempro, Premarin, just estrogen without progesterone for like almost 10 years from the gynecologist who just kept refilling it for her without appropriate examination. Comes into my office all these years later for a first-time visit, ended up having endometrial cancer, had been on unopposed estrogen for years and years and years. At some point in that time, there was a miscommunication if that patient had a uterus or not, and ultimately it can lead to a lawsuit from the prescribing provider, and it's dangerous for the patient. So always keep that in mind. Very important risk factor in your clinical decision making for postmenopausal women. Okay, these are the degrees, the grading of uterine prolapse. And obviously with this one, it's like completely coming out of the vagina. Some of these can be managed with Kegel exercises and strengthening of the pelvic floor. Some of them don't need to be managed because they're not causing the problem. Obviously, surgery is needed if it's like this. There are devices called pessaries. There's a bunch of different kinds of pessaries. They've been around for years and years. I actually have a significant number of patients within my practice that use pessaries, that I manage them for them. But they're little devices that go up the vagina and just kind of, hold things in place, keep the uterus up by putting, pressure on the anterior and posterior walls of the vagina, or just filling up that space. But they can be a good, cheap, non-surgical option for your patient who maybe is not wanting surgery, can't afford surgery, or is not an appropriate surgical candidate for this. And so, something just to keep in mind. This is a complete uterine prolapse. You can see the cervical os. We don't even need a speculum exam to do that because it's completely prolapsed out. And these are, I'm assuming, fibroid tumors. I had a patient one time that came into my office for a sinus infection. I was palpating her abdomen, and her uterus was firm, and it felt like she had a mass in her pelvis, and it was like the size of a 20-week, it was up to her umbilicus. And I asked her about it, and she's like, oh, it's been there forever. And I'm like, it's just grown over the last few years. And I ended up imaging her, and she had a benign fibroid, but it had gotten so large that it actually was putting compression on one of her ureters, and she had hydronephrosis. She had, a kidney that the function was being compromised because she had this huge mass in her pelvis. Ended up having the surgery, lost about 10 pounds, went down 2 sizes of jeans. Kidneys are fine. So we often don't think about these benign tumors sometimes just causing issues, but they certainly can, especially when they're compromising the nearby structures. Our adnexa, ovarian cysts would be where we would, that would be the location. They would be fluid-filled sacs within the ovaries. Ovarian cancer is categorized by where it arises at. And you don't always feel that. I had a patient diagnosed with ovarian cancer within this last year, and the tumor had just gotten so big that I couldn't feel it. It was in a location. I couldn't feel it like I could the uterus. I couldn't really feel it on her lower abdominal exam, but when I went to do the bimanual exam, it was not really in her pelvis anymore, and so she did have a little bit of tenderness on it, but I didn't feel a huge mass because the mass had actually become so big that it was no longer really within that adnexal area. It had kind of gone higher up and further back within the pelvis, but that's why that exam is so important. Tubal and ectopic pregnancies can occur also, and that's a pregnancy outside the uterus. And those are not viable, and those can be life-threatening for the patients. And so your patients with pelvic pain, you need to be doing pregnancy tests on them if that is even a suspicion in your mind. Even if they've had a tubal, if they missed a period or they're having any kind of pain, you need to be screening for that, because that is a huge, can be a life-threatening issue for them if that is missed. This is a very large ovarian cyst. And they don't always have to be tender. This is an ectopic pregnancy over here that ruptured. Pelvic inflammatory disease, infection of the uterus, fallopian tubes, and other reproductive organs. Sometimes you can get abscesses in that area, tube ovarian abscess. Keep in mind, your fallopian tubes are as delicate as a strand of hair. And often, if you have a pretty significant infection in that area, it can, sorry, I had to plug my computer in. These infections can cause abscesses and other problems that can lead to infertility and just some really significant issues. Perforation of bowel and just lots of bad things if not treated appropriately. Your fallopian tubes are as delicate as a strand of hair, and you can tell how, if you have an overwhelming infection, inflammation, or an abscess in these areas, how they might damage where you really don't have full function of them and you have scarring in the future. So really important to educate your patients on not getting these infections and having safe sex and getting it treated quickly whenever they realize there is a problem, not letting it go on and on and on. But they can have some very serious complications. Salpingitis is the inflammation or infection of the fallopian tubes and is often associated with PID. And this is PID, and this is these are adhesions, which scarring and just inflammation. That's got to be horribly painful. And infants and children, ambiguous genitalia. Sometimes when newborns are born, you can't tell if they're male or female because they may have, in response to the mother's hormones, their clitoris maybe, or penis, you may not be able to tell clearly. Sometimes there's distension of the vagina due to accumulation of fluid, due to a congenital vaginal obstruction, so it's important to do that newborn exam. Vulvovaginitis, inflammation of the vulvar and vaginal tissues. This is some ambiguous genitalia of the newborn. And often, there are some chromosomal things, hermaphrodite, things like that, but sometimes if you see this and it is quite prominent, if you'll just give it a little bit of time, it will resolve on its own. Pregnant women, premature rupture of the membranes. Obviously if we can't carry our baby to term, infant morbidity and mortality is up, as well as that to the mother. Sometimes the cause is unknown. It can be due to excessive amniotic fluid, infection, something going on with the mother like HELLP syndrome, or maybe trauma. They can experience bleeding in early pregnancy. Again, ectopic pregnancy always needs to be in the back of your mind. You can see bleeding late in pregnancy, and in that case, it would be an emergency. The placenta could have abrupted and separated from the site, and therefore, the mother can bleed to death and die, or the baby will lose its oxygen and nutrient supply, and so that is certainly an emergency. Older adults experience often atrophic vaginitis, inflammation of the vagina due to thinning and shrinking of the tissues, as well as decreased lubrication, and we can treat that with a topical estrogen if that's all they're experiencing. There's a new medication now that is specifically, it's in the same class with Avista. I can't think of the name off the top of my head, but it is an estrogen receptor modifier, but it is approved just for that indication of vulvovaginitis. Also, you see some urinary incontinence as well. So this is a part that I will update on the PowerPoint, but cervical cancer in people under 21 is no longer recommended. So we start screening age over 21 in normal risk women. We don't screen women age over 65 if they've had adequate screening. We don't screen women who've had a total hysterectomy for benign reasons, and we so now they recommend age 21 to 30 be screened every 2 years instead of annually. Standard or liquid cytology. Women over age 30 who have had 3 consecutive negative tests can be screened every 3 years. So they may need to be screened more frequently, or we may need to go against the guidelines if they have HIV or are immunosuppressed. I screen my women in my practice. I talked about that I have 2 that have had DES exposure and have some abnormalities from that. I screen them annually despite them being over age 35, or, over age 45, really. Or a history of treatment for CIN2, 3, or cervical cancer. Obviously, they don't fit into that category. And that is the end of the presentation.